public and from journalists. If we first go to slide one. Slide one shows the testing capacity and the number of new cases. The top chart in the slide shows the number of tests. And that number of tests as of the 2nd of June was 135,643. This is different to testing capacity, which stands at just over 200,000. And as I said yesterday, this demonstrates that there is spare capacity in testing. And so if you have symptoms of coronavirus, that's a fever or a new dry cough or a change in your sense of taste or smell, then please do go and get a test from nhs.uk/coronavirus or by phoning 119. It's incredibly important that we can trace the virus by ensuring that anybody with symptoms has a test. And of course, we're rolling out testing across care homes and making sure that staff in hospitals get the opportunity to be tested as well. The bottom chart on the slide shows the number of confirmed cases. And this is 1,613 as of, again, the 2nd of June, and brings the total of number of cases confirmed in the UK to 277,985. And although the 1,613 figure is slightly higher than yesterday, we can see that the 7-day rolling average continues to fall. Second slide, please. The data from hospitals show that those new admissions to hospitals in England has fallen to 436. This is down from 471 on the 24th of May, so just over a week ago, and down from a high of 3,121 on the 2nd of April. This figure of 436 admissions to hospitals in England with COVID-19 is the lowest figure since the 20th of March, and it demonstrates once again that we are making progress against this disease. Again, as yesterday, the proportion of mechanical ventilated beds that are occupied by patients with coronavirus remains at 9%. Next slide, please. Thank you. Just like yesterday, the number of people in hospital continues to fall. 7,607 are now in hospital with coronavirus, and that is broadly falling in each part of the country, but for a little bit of day-to-day movement in some of the areas. For instance, as you can see right at the end of the chart for the North East and Yorkshire, but we keep that very closely under review. But the overriding trend, as you can see, is downwards. The next slide is the number of deaths, and sadly, on the 2nd of June yesterday, 324 deaths with coronavirus were recorded, taking the total to 39,369. And we mourn each one of these. And we try to keep these data as accurate as possible, including where we find in the past in some cases there are deaths where we discover that there has been a connection to coronavirus, and we add those into those data. So we can see that, again, the trend is broadly down, but there is still some way to go. And after the weekend effect, which we've seen each weekend in terms of the number of deaths recorded, because this is according to the date these are recorded, we've seen that rise on most Mondays. And sadly, the figure is 324 today. Next slide, final slide, please. The final slide reports on data from the Office for National Statistics, which was reported this morning, and reported a total of 48,106 deaths in the UK, where COVID-19 was mentioned on the death certificate. And you can see that this number is falling. The top chart shows those data and shows where we were on the recorded daily deaths data for the period that corresponded to these data coming from the ONS. On the bottom chart, we can see the place of occurrence of those deaths, and you can see that both the number of deaths and the proportion of deaths that are in care homes, both of those are falling. 27.3% of deaths occurred in care homes in the latest ONS data to the week of the May the 22nd, bringing the proportion overall of deaths in care homes down to 32.5%. We don't capture in these charts, but we do capture in a report published by Public Health England today further data, some of which are much more troubling. The PHE investigation into the way in which the virus targets people unequally and disproportionately has been put on the website. And this is a particularly timely publication because right across the world, people are angry about racial injustice. And I get that. Black lives matter. And I want to say this to everyone who works in the NHS and in social care. I value the contribution that you make, everybody equally. And I want to say it right across society too. I want to thank you, and I want you to know that our whole country cares about your well-being. And I value too those who come to our country to work in the NHS and in social care. And I love that this country is one of the most welcoming and tolerant and diverse. That goes for the whole country, and it goes especially for the health and care system. As I said in the House of Commons earlier, PHE's investigation found that age is the biggest risk factor for coronavirus. Next, gender. Living in a city is a risk, and being black or from a minority ethnic background is also a significant risk factor. There is much more work to do to understand what's driving these disparities and how the different risk factors interact. And we are absolutely determined to get to the bottom of this and find ways of closing that gap. And I'm delighted that Kemi Badenoch, the Minister for Equalities, will be taking this work forward, working with PHE and many others. We value the contribution from everyone to fighting this virus. Everyone has a contribution to make. And of course, the thing that every single person can do is to make their personal contribution to fighting this virus. In the first instance, things as simple as washing your hands, following the social distancing rules, and of course, if you have symptoms, please self-isolate immediately and get tested to protect your friends and family. So let's keep going and we'll get through this. We'll now turn to questions. The first questions are from members of the public, and the first one is from Danny from Huddersfield. Danny.
Over the last week, a number of measures have been relaxed. If the R rate now begins to increase because of this, how will you identify which measures need to be reintroduced to bring it back under control?
Well, that is a really important question. I'll ask John to come in a second. The package of measures that we've taken, we judge to be safe, but of course, it depends on how people behave, and so it's important that people follow the social distancing guidelines, even as they're changed. We'll keep it under review. We then, if we need to make changes, we can either make them at a national level or a local level, and that'll be determined by where we see any outbreaks, if we see them. And then at a national level, we can look at right across the board. And of course, we've been clear from the start that if we need to, we will bring in further measures. But we've chosen these measures in order to be able to relax some of the most stringent parts of the lockdown whilst also keeping people safe. John.
Yes, thank you, Secretary of State. I think the answer, Danny, is that it would depend on how the virus was coming back. Key to any public health control, and particularly for this virus, is the surveillance information that we have, including special surveys, but also routine surveillance, for example, from general practice. So if it was, if the virus came back in a particular setting, whether it was a healthcare setting or perhaps in a prison or whatever, then you can undertake a lot of testing and infection control in that setting. If it comes back more widely in particular groups, then there would be different measures that could be taken. So it would be in response to the way in which the epidemiology, the counts of the numbers of cases were increasing. It seems likely, from the experience of other countries, that if we do get recrudescence, which is the technical term of the virus, it would be patchy. It would be in localized areas, and that's why we are keeping that under very close control. Thank you.
Thanks very much, Danny. The next question is a written question from Barbara from Bridport. And Barbara asks, when will those members of the general public who suspect that they may have had COVID-19 be able to have an antibody test, and how will this be rolled out? Well, this is another great question, Barbara. The answer is that in the first instance, the antibody tests are being used by those in the health and social care sector. We are delivering around 40,000 a day across the NHS and social care, and just over 40,000 a day on the latest figures. And then we'll roll them out across the country. We haven't yet been able to pin down the science of whether having antibody means that you are at lower risk of getting the infection again, and critically at lower risk of transmitting the virus. We've got tests in the field to find that out. So we will be rolling out antibody tests more broadly, and we've bought a huge number of them to be able to do that. They involve a phlebotomist being able to take blood so that you can analyse that blood, which means that we've got to roll them out at the pace that we are, and we're trying to expand the rate at which we roll them out, because I entirely understand your yearning to know. Thanks very much. Questions from the media. If we go to Rhianna Croxford from the BBC. Rhianna.
Thank you, Secretary of State. Many people from black and minority ethnic backgrounds will be confused why it has taken 6 weeks for the government to simply confirm what studies have already shown, that they're dying with COVID-19 at significantly higher rates. Deaths from all causes in this period have been up to 4 times higher on average for people from these backgrounds, and this hasn't been fully explained by today's review. Firstly, how can you explain this disparity, which hasn't just been caused by the virus, and why haven't you done more to protect and support these communities? And if I could also please have a response from Professor Newton. And secondly, on behalf of a colleague, you've been criticised by the stats watchdog for the presentation of the virus testing figures. Isn't that embarrassing over such an important policy area?
Thanks very much. I will, if I just address the second question first, and then I will, both John and I, I'm sure, will answer on the first, which is so important. On the second question, the way that we present the stats is the best that we can in the having built the testing program so rapidly over such a short period of time. We are working with the stats authorities to be able to present these statistics in a way that they're happy with, and to make sure that we're as transparent as possible. I spoke to Sir David Norgrove today, who is the head of UK Statistics Authority, and we'll be working with them to make sure that these statistics are constantly improved. But the way that we present them is the simplest way of presenting a very complex picture of the overall 5 different pillars of testing, and that's the approach that we've taken. On the first part of your question about the report from Public Health England, I think this is an incredibly important area. I've been really struck by the clear difference in the proportion of people who are dying with COVID-19 from ethnic minority backgrounds, and I wanted to get to the bottom of it. So I asked Public Health England to do this work by the end of May. They've done that, but you're absolutely right that there's much more work that needs to be done, and this report shows that. So I've asked the Equalities Minister, Kemi Badenoch, to take this forward and to look into the causes and what further can be done. And Professor Newton's been involved in this work from the start.
Yeah, so thank you. I mean, just on the reporting of the statistics, it's worth bearing in mind the objective of the testing program was to build a capacity of tests to respond to the pandemic, and it's really what we do with the tests rather than the numbers which matter. So at the moment we have a falling number of infections, and what we're really keen to do is to have really high quality testing that's delivered quickly and very available. So actually just the numbers of tests isn't a measure of how effective the program is. It's whether we're testing the right people, testing them quickly and getting the results back. So we're happy to report the numbers in any way that we're asked to. On the review is an important piece of work. There was a great deal in it, a lot of different factors looked at. Normally a report like this would take us a good 6 months, so we've actually produced the sort of analysis that in a relatively short time. As you say, some of these data were already available, so the Office for National Statistics and other research studies have already published, so we've confirmed that, and it's important to have confirmation from a number of sources. As you say, we weren't able to look at all the potential explanations, but in particular, you mentioned the all-cause mortality being 4 times higher, or actually 3.9 times higher in black men, for example, than in normal times, and it's raised by 1.7 times in white men and 2.9 in Asian men. So there are a number of statistics in there. It's quite a long report, and there's a great deal of background information and detailed information that we think will be helpful. What we'd really like to do now is to get a lot of discussion about all these elements, in particular with a lot of the people involved and the various groups involved in responding to it. So we think the report will be helpful. Some of it was available before, but there's quite a lot of new information there, and it's not easy to go directly from the analysis to making recommendations, and we need to get the report widely disseminated and widely discussed before, I think, deciding exactly what needs to be done. But clearly there are some fairly obvious conclusions that can be drawn even from the data that we have.
Can I please follow up on that?
Yes, of course, yeah.
Just saying, firstly, thank you for acknowledging that Black Lives Matter in your opening speech, but lots of people are already going back to work scared that they're not being protected, and there'll be no measures announced today, as we had expected, perhaps be put in place to protect them. Can you say anything to these communities? And if not, can you give us a time frame or a deadline when they will get recommendations about how they can protect themselves going forward, considering that this risk won't be going away?
Yes, absolutely. The number one thing I'd say is that for anybody in a higher risk group, the most important thing to do is stringently to follow the social distancing guides, including the work on social distancing at work that's been published. So there is specific guidance for social distancing in the workplace. So for all of the different high-risk categories that the data demonstrate, it's really important that people follow those social distancing guidelines very stringently. We've been very clear about this from the start about those who either have a medical condition, and as the PHE report says, age is the number one risk factor because around 90% of deaths are amongst the over 65s. So the direct answer to the question is the same as to everybody, but with more emphasis, which is that the social distancing is the best way to keep yourself safe and keep others safe, alongside the hygiene and washing your hands and making sure that if you have symptoms, get a test. And I totally understand the concerns that people have, and I understand the anger that people feel more about racial injustice more broadly, and I share it, and we want to tackle it. I fully acknowledge that, and it is very, very important that we address that, as I'm trying to do within the NHS and social care that I'm responsible for, and I think we need to do across society as a whole. Thanks very much, Rhiannon. Is that okay? Yeah. Emily Morgan from ITV.
Hi, if I can pick up on something that Rhiannon said, you launched this review, Secretary of State, this review published today with a huge fanfare to look at how COVID-19 was affecting ethnic minorities. One of the objectives to the review was to make recommendations. Where are those recommendations, and will you be publishing anytime soon?
Well, absolutely. We need to go through the next stage of work, to make sure that we take into account all of the different considerations. For instance, the PHE report sets out that it doesn't take into account comorbidities, different occupations, because different people in different occupations have different risk factors, and of course the other health factors like obesity. We've got to make sure that all of those are taken into account and scientifically, rigorously understand the causes behind the data that are clearly shown today, and take that and take the lessons from there. John?
Well, yes, thank you. I mean, I think the recommendations there are recommendations there, but they're more to do with the fact that these are important data for people to be aware of, because as Secretary of State has said, I think even understanding the levels of risk associated with different factors is itself important in designing programs to protect people. And in fact, the NHS has already started a process of risk assessment for staff using these sorts of data. So there are recommendations there, but there are still some questions. I mean, what we do show is that there's no simple, if you take, I mean, there's a lot more than just the ethnic differences in the report. There are differences to do with levels of deprivation and where people live and occupation and so on. And all these causes are the causes of health inequalities anyway. And actually what the report emphasizes is the fact that what COVID-19 has done is to emphasize the existing health inequalities in the country. And it shows us again that we need to address those inequalities, whether they're to do with deprivation or to do with people's background. So in fact, to some extent, the recommendations that have been made before about similar issues still apply. What we have put forward is some data that can be used. Secretary of State mentioned the relevant minister and the Race Disparities Unit, who have already looked at the data. And I think we will be seeing some recommendations coming out. But it is important that those recommendations are widely discussed with a lot of other groups, not just from Public Health England. But we think the data are going to be important for those processes.
Thanks. Yes, of course, yeah.
You mentioned risk assessments, and obviously risk assessments are now happening for ethnic minority members of staff in healthcare. But what about the rest of the population? Given that we know that ethnic minorities are being disproportionately affected by COVID-19, shouldn't all ethnic minorities now be put in an at-risk category to protect them?
Well, if I may, Secretary, the key point of the study is it shows, although clearly outcomes are worse for people in black and minority ethnic groups, that is not necessarily because of their ethnicity, but exactly as you say, it may be related to their occupation or to other reasons why they might be at a higher level of exposure. So one just has to be a little bit careful in doing that risk assessment. One has to look at the causes of increased risk, which may be as much to do with other factors, not necessarily someone's background per se, although there is probably an element of that as well. So the report, if nothing else, emphasizes the complexity of what we're seeing. So really we're urging people not to jump to conclusions and institute measures which are not really justified by the data. So there's an element of caution in our results, as well as obviously pointing out these obvious inequalities. Thank you.
Thanks, Emily. Next question is from Ben Kentish at LBC. Ben.
Thank you, Secretary of State. Good afternoon. I wanted to ask you about the ONS figures this morning, because 2 months or so ago, at the start of the lockdown, the government was predicting a death toll of between 7,000 and 20,000. The ONS this morning revealing that the total excess mortality since the end of March is 3 times that, and more than 3 times that, at about 62,000. I wondered if you had any sense of why you thought that was, and therefore what lessons we could learn about that for the future. And if I could, just one for Professor Newton. Testing capacity has increased significantly, but still about a third of it each day is going unused. Just wondered how you plan to use that spare capacity, and whether it could be used for people who have been told to isolate by the track and trace test and trace system without symptoms, to decide whether or not they do indeed have the virus. Thank you.
Thanks very much. On the first question, I'll take the first question, then ask Professor Newton to answer the second. On the first question, we didn't make a prediction of the impact of this disease, other than right at the start when there were scientific predictions made, which have been published, showing that unmitigated, with no measures, the death toll would have been around 500,000. And that led to a whole series of changes, including the social distancing and effectively the lockdown, because that was unacceptably high. And we are completely and fully transparent about the impact of the disease. And I welcome the ONS's vigilance in measuring it. The good news from the ONS stats this morning are that the number of cases, the number of deaths, is coming down, and also the fact that the proportion of deaths in care homes is coming down, given that that's been a very big focus of attention. Professor Newton.
Yeah, thank you very much. So it's a very good question about what are the priorities for the testing programme. So there are three priorities. The first is to support the test and trace programme, and the Secretary of State has said we are really keen for anybody with symptoms that might be coronavirus to come forward, have a test, and so that we can give a definitive answer, and if they are positive, they can be entered into the test and trace programme. And I should say, actually, we were asked yesterday about some of the statistics, but there are thousands of people already who've tested positive, who've been successfully fed into the test and trace programme, and they have using the online tool and identifying contacts, and there are thousands of contacts who've been successfully identified and agreed to self-isolate. So that programme is going well. We don't, in fact, recommend testing for people who don't have symptoms, because if you don't have symptoms, it is unlikely to be positive, and even if somebody who's incubating the virus, the test may well be negative. So if you have a test if you're a contact and during your 14 days of self-isolation, if you have a test and it's negative, you still have to complete the 14 days isolation. So there is little utility in offering tests to people who are contacts, unless they develop symptoms, when of course it is worthwhile. The second priority is to support the NHS in infection control and other settings like care homes. So we're doing a lot of testing of staff to make sure that it's safe for people to be in a care setting or in the NHS. So that's a substantial requirement. The numbers of positive tests, and particularly asymptomatic positive tests in those settings, are coming down. So we are learning from those results to design infection control programs for the future. And then thirdly, we're using the test to support really large-scale surveys. So every now and again you see a blip in the numbers of tests done when we do a lot of tests for a survey, whether it's for the Office of National Statistics or one of the other, the Imperial College survey or so on. So those are the three priorities for testing. We are using a good proportion of the tests. And of course then there are the antibody tests, which are being rolled out first in health and care staff to understand how the infection has spread.
Can I just come back on your answer, Secretary of State?
Yeah, of course, yeah.
Thank you, because there were forecasts published by members of SAGE, Neil Ferguson, for example, and he said today that the UK had been much more heavily affected by the virus than expected. So I did wonder if there was any analysis going on, and if you could share any of that about why that might be and how we could avoid, if there was a second peak or a future epidemic, how we can avoid those same things happening again.
Well, it's undoubtedly true that we've had a very significant impact from this virus. There's no doubt about that. And we've been learning all the way through it how best to deal with that. In fact, the test and trace system that we've built over the past few weeks and that's been up and running for the past 5 days is one of the lessons that comes out of it, the absolute vital importance of having a system that is big enough to be able to trace as many of those who tested positive as possible. And this, in fact, ties in with an additional answer I was going to give to your second question, which is that Professor Newton gave the long answer, if you like. The short answer to the question of the gap between tests done and capacity is that we have spare capacity. This is a good thing, but I would urge LBC listeners and everybody else in the country to use the capacity if they need it. If you need a test, you can get one straightforwardly, go on the website, and you are not only protecting yourself, but you're also helping us to trace the virus and control it, and therefore keep the country safe. Thanks very much, Ben. George Parker from the FT. George.
Thank you. It's a question about the government's plan for a blanket quarantine, a 14-day quarantine on people arriving from overseas. Question, first of all, to Professor Newsom. What is the scientific rationale for having a quarantine against people coming in, for example, from a country like Greece, which has very low levels of coronavirus, into this country? And would you support the idea of an air bridge between countries with lower infection rates than Britain into the UK? And a question to you, Secretary of State. You said on May the 12th that people wouldn't be taking overseas holidays this year. Is that still your advice?
Well, do you want to go first?
Well, I should say, by the way, that I'm not a member of SAGE, and it would be SAGE whose advice is the basis for this. But the principles are clear that obviously we, just like in this country, if somebody might be at risk of having the virus, we need them to be isolated during any period when they might be infectious. And if people are coming into the country, then they already have to be treated as an unknown, and therefore there's a quarantine. Now, if there are two reasons why we might not do that. That would be if the risk of them having the virus when they come from another country is so low that we would just take the chance, that the chances of them becoming infectious are very low. And I think at the moment the judgment is that it's too early to say that, and therefore it's better to be cautious for people travelling. And secondly, if we are able to very quickly respond with a test and trace programme, then we could cover it in that way. So if travellers are able to be tested and self-isolate in response to contact tracing, just like if you like a domestic new case, then that would also be a way of dealing with it. At the moment, I think caution is won the day, and SAGE's advice is that quarantine is appropriate. But as I say, it's not my direct responsibility. But I'm sure those are the principles on which the advice is being given.
Thanks, George. On the specifics, I was actually asked this, I think, late last week, and I said I was more optimistic than previously. But clearly, the number one priority is keeping the public safe. And that is the overriding principle, and it has been throughout this, and hence many of the changes that we've brought in. The next question is from Sarah O'Grady. Yes, of course. Sorry, you want to come back?
Can I just quick follow up on that?
Sure.
Given that the UK has one of the highest infection rates in Europe, can you give any indication of which other European countries are interested in the idea of an air bridge with the UK?
Well, this air bridge idea has been floated, and I know there's been a lot of discussion about it, and I know that some countries have been mentioned in the media, but that is a piece of work that's being done by the Home Office and the DFT, and I'm not going to tread on the toes of my colleagues, no matter how tempting it is. Thanks, George. The next question is from Sarah O'Grady from the Daily Express. Sarah.
Hello there. My question is to you, Secretary of State. The spotlight has shone on the pressures faced by our social care system through this coronavirus pandemic like never before. And I would like to know, please, so I could tell readers of the Daily Express, what are your plans and what is your time frame for the long-promised radical reform of social care?
Well, I'm glad to say, Sarah, that we absolutely need to make those reforms to social care that have been, in my view, pushed to the side for too long. We made clear commitments in the manifesto, which was only back in December, and we have been working on that piece of work even during the coronavirus crisis. It's incredibly important to me that we put social care on a sustainable footing. And I think one of the positive things amid the terrible things that have happened during this crisis is that people have recognised social care as for just how important it is. And I think everybody who works in social care has seen the whole country value them. We need to follow that up with reforms to the way that social care is supported to make sure that more people get that dignity in their older age, and the people of working age who are in social care get the support that they need. So I'm very keen to. I'm determined to push forward the social care reforms that I know so many readers of the Daily Express are interested in.
can you give me an example, please, of one of those reforms? Could you give us an idea of perhaps the time frame?
Well, the time frame has been clear, which is that we've got to get these reforms done in this Parliament, and the Prime Minister has previously said that we'd get them set out this year. That was before coronavirus. We'll still try to do that, but it is not straightforward. What I can say is that the crisis itself has demonstrated many of the reforms that are needed, like closer working and collaboration between health and social care, like the increased financial support, which we'd already committed to for social care, and then we've put more in during the crisis, and making sure that some of the injustices in social care are taken away, especially about how it's paid for. Thanks very much. The final question is from Vic Mattoon from The Voice. Vic.
Secretary of State, many thanks. I'd like to ask two questions, if I may, and address them also to Mr. Newton. Given the disproportionate way in which COVID-19 has affected people from Black, Asian and minority ethnic communities, there's understandably a lot of concern, a lot of anticipation about this report, the Public Health England report, and what it might say. However, the disappointing lack of recommendations is certainly going to affect many. Already we've had a number of emails from readers of The Voice citing this as another example of government indifference to the kind of inequalities that you mentioned earlier on in your address. How will the government address and reassure members of those communities that this isn't just another report? The second question I'd like to ask, as you know, the statistics show a clear link between the people working in public frontline communities, frontline jobs, and also their chances of contracting COVID-19. Many people from BME communities are in frontline jobs such as health, healthcare, transport, social care. But local authorities around the country have been very quick to protect BME employees through things like risk assessments. How will the government follow their lead?
Well, thanks very much, Vic. And I in a way, the second question answers the first, in that we've already taken action because it's been clear right from the start. You know, I remember that the first 4 deaths of doctors were all people from Black and Asian minority ethnic backgrounds. I think 3 of the 4 had come to the UK to serve in the NHS, and it really struck me, and this was right at the start, that there was clearly a disparity, and we've seen that disparity. And I think in your second question, you've touched on some of the reasons, and we need to do more work, which is why we've published this and are saying we're taking it further. Because the link to the occupations that people do is an important part of this conundrum. And putting in place risk assessments for people who are in high-risk occupations has been something that we've already been doing the work on. What we need to find out, and we don't yet know from this report, is what over and above the impacts of being in a certain occupation, like, for instance, as you say, being more on the front line. And one of the biggest impacts is of people who work in transport, where you can't isolate, so like taxi drivers, and how much of the disproportionate number of deaths that we've seen from people from BME communities are due to the fact that there's a higher proportion of people from those communities who work in the sorts of occupations where the risk is greater, and how much is down to, for instance, the differences in housing, because we know that urban areas are more badly hit than rural areas. And so it's the wider co-determinants that we need to get to the bottom of. And that's the work that, along with PHE, that Kemi Badenoch will be leading in the next stage to make sure we look as broadly as possible. And all the way through this, we've been putting in place the actions that we think have been needed from the evidence that we've got, and we need to keep doing that. John.
Oh, thank you, Secretary of State. Yeah, I mean, the purpose of the report was to try and get every bit of information we could from the existing data, try and understand how the different factors work together. So not just ethnicity, but the other factors which are often working alongside ethnicity. And many people, of course, suffer from multiple disadvantages as well. So we're trying to put all that into context and really present it as clearly as we could. And it is complicated. Even after we've done the analyses, it is still a complicated picture. So trying to get that absolutely clear so that people could then take it forward and develop the right recommendations. And I think there's the way we would do this is it is such a way that the people who we're really trying to put the information into the hands of people who can use it to make a difference, and that's often it's not us as the public health authority. It's more likely the people that you work with and know who will know how to use these data to make a difference to people's lives. So there's a whole range of people who need to contribute to these recommendations, certainly not just us as Public Health England. So we've done the very best we can to understand what the data tell us already. There are some things that we still don't know from the data, and there's a research program that has been kicked off to try and elucidate some of the genetic analyses and so on we haven't done yet. But we've done the very best we can to make those data available to people so that really good recommendations can be developed, which will really make a difference to the outcome. But thank you.
Thanks. Have you got a...
Yeah. If I may ask, so you mentioned that there will be a follow-up report and inquiry. Do you have any timelines as to when that follow-up report, you mentioned it will be headed by Kemi Badenoch. Do you have any timelines as to when that might be? Obviously, the concern on this issue is that, given the scale of the issue, it's just report after report. And obviously, there are many people in BME communities who really want to see some serious action and some serious recommendations.
Yeah, I get that yearning, and we will put action in place as soon as we can. We won't wait for a report. I've got to talk to Kemi about a timeline for it, and so I'll have to get back to you on that one. But I totally understand the urgency, the importance, and the sensitivity of getting this right. Thanks, Vic. Thank you very much indeed. That ends today's Downing Street Coronavirus Daily Briefing.